as Malia and I were both doing, was putting salads down our throats just minutes before we got on here. So hope you were all able to get some food in your stomach, or you could eat along, because that doesn't really matter either. It does to me though, for myself. You would anyway. So my name is Monica Meyer, and I'm going to be talking today about Autism 101. This is kind of the basics actually, and not only are they the basics, I'll give you some information about just different things that are going on in our state, as well as genetic studies, research, and as well as specifically the characteristics of autism. And thank you, Malia, for inviting me to do this presentation. This is one of my favorite ones to provide to families. As I am a family member, I am a mom of a young man who has autism. He also has an intellectual disability, as well as an intractable seizure disorder, and some health, significant health issue related to the gut. If you will hear a lot, if you don't already know, the brain-gut relationship between autism in the diagnosis of autism is pretty prevalent for our kids to have stomach problems or GI issues. So can I just ask not where, because most of you, I mean, it doesn't matter where, if you are a parent, or if you could just give me your name. You don't have to show yourself on the screen. You can just unmute yourself. And if you want to, I'll identify who should go. And if Charlene, if you wanted to start first, and just who you are, and if you have a child on the spectrum, give us a little information.
I do not have a child on the spectrum, but I do childcare. I provide childcare for 3 children in the same family with varying degrees of autism.
Mm-hmm. Wonderful. Thank you.
I myself have a daughter with autism and ADHD. I think that she would have been diagnosed as pervasive developmental disorder before.
Mm-hmm. And I now I forgot your name. Yeah, the one that just says iPhone. What your name?
I can go. I'm Alexis. I do not have a child with autism, but I do work with a lot of kids on the spectrum. I have done DDA. I've done Navy respite care, and
Nice.
I also work for what's called sorry, my voice. CORE's Children's Crisis Outreach Response System. Yep. So I work with a lot of the kids on the spectrum in that realm too. So
great. Welcome. Thank you for wanting to get more information. Mm-hmm. Angelica, excuse me.
Hi. Yeah, I don't have a child with autism, but mm-hmm. I work with adults with special needs, and I'm in the process of becoming certified with the state to provide respite care one-on-one with adults with special needs.
Awesome. Well, very needed profession. Thank you.
Thank you.
Andrea?
Hello, my name is Andrea, and I'm the director at a local preschool in town. And I also work with the OESD, and I am the infant toddler fine coach. So I go in and to different programs, and I get to work with teachers with behavior issues or that serve and return aspect.
Sure. Awesome. Welcome.
Thank you.
Laura?
Hi, am I on?
Yes, you are.
Oh, okay. I am a caregiver and guardian for an adult relative with autism, and a couple years ago myself was diagnosed on the spectrum.
I forgot to say that I also am just diagnosed on the spectrum. I took your directions literally, Monica. I just
Right,
talked
I
about my
know.
kid. And also, I have a nephew that I'm raising who's undiagnosed and my son who's undiagnosed because at the time autism was defined differently.
Differently. Yeah. Thank you, Laura. Suzanne. Suzanne, can you unmute yourself? Or not? Debbie, do you want to go ahead? Hi, Debbie. You want to introduce yourself?
Try, but my connection keeps kicking me off. I'm so sorry. Yes,
Oh, that's all right.
a newly diagnosed who is a teen, just coming into understanding what we have and what we can do and so forth.
Sure.
So
Great. Well, welcome.
new into this whole thing. Sorry if I drop off.
No worries. No worries. So Suzanne, I don't know if you're having difficulty with your connection as well, but I'm glad you're here. And I'm going to go ahead and get started. And as Malia had suggested in the beginning, you are more than welcome to ask questions. Just I can stop at any time, or if you prefer to type your question in the chat, Malia is going to keep her eye on it, and so that she's going to be able to say, "Oh, Monica, there's a question in the chat," and then I can answer that as well. So I'm giving you a lot of information today, and so I hope you will go to additional trainings. This is just kind of a fast and furious overview, but hopefully you will gain some really good insights that you too can follow through with either more research, or you can certainly reach out to Malia. She is part of the Parent Coalition, or you can also reach out to me, as my email is at the very bottom of the slides. Actually, I will type it in here as well. I'll put it in the chat. Oops. So my email is there as well. And let me just make sure, because there were some folks that came in here after I posted. I have posted the Google link that has the handout for this evening, so you can download it for your own information. And if you just go into the chat, follow the Google Drive, and it will take you to the presentation. So I'm going to be using a couple of different terms, or actually a few different terms throughout this process. When my son was born a few years ago, we really fought for the ideals of having person first or people first language, meaning a person is a person, and then they have a person who then has a disability. And so in the era that there are two things going on: people first language, which is still something that is very profoundly used in the developmental disability community, except there are people now who are self-advocates who want to be referred to as identity first, which means I'm an autistic individual, for they feel that that is their identity, that is how their brain functions, and they would prefer to be called autistic. So you're going to hear me use both of those this evening. I'll use all that throughout the whole throughout this whole presentation. So really the first word of autism, it really comes from the Greek word auto, which means like you have an autobiography. It is a book written by a person. So it's the self. Auto means self. And so that's where the first word came for autism. And not to say that it is a narcissistic condition, because it's not, but it's selfism in the fact that the person with autism sees the world through their eyes. They don't always see the perspective from somebody else's point of view. And many, many years ago, there was really the doctor who coined the term autism or autistic to really define some folks that were identified as having a mental illness, referring to as schizophrenia. But it was really kind of like, it doesn't really fit, but that's what we're going to give the person, this identity, and which that was when it was first identified. So when you think about it, really it has been about 100 years that autism has really started to become, really looked at differently. And so Leo Kanner was the one who, in 1943, along with Hans Asperger, who were both psychiatrists, one in Germany and the other one in Austria, that really did publications on people who were seemingly autistic. And Leo Kanner was the one that really published some information about describing these 11 children that he worked with and how they defined autism today. The unfortunate reality, and you will hear a lot of individuals with autism or autistic self-advocates that talk about Leo Kanner, as well as Hans Asperger, because they both were under the Nazi regime in the 40s. And so this is, the publications are things that have brought autism to the forefront. How they got it was not in the most, is not what we see research done today. And so I just wanted to make sure that you have that information. There is information about Leo Kanner in this link here, which is www.neurodiversity.com, library Kanner 1943. So you can see it's in that time frame of what World War II was. And so, as Malia was saying, probably when, your daughter a few years ago, there was, before the DSM-5, which is the Diagnostic Statistical Manual, the revised edition 5, when it was the revised edition 4, it had basically a triad of impairments. As of recently, it is referred to as a dyad of impairment. And so, and it has also defined really some specifics about autism that were otherwise not really recognized, I should say. So I'll get into that here in just a few minutes. But there are two components to looking at a person who is diagnosed with autism, and that's what a good diagnostician will look at, is that there's a persistent deficit in social communication and social interaction across multiple contexts, and manifests by the following: current or by history. And it's basically deficits in social emotional reciprocity, understanding that there is perspective from other people's point of view, being able to share information, being able to come in contact with somebody, to communicate with reciprocal understanding. So when you think about a person with autism, their first access to anybody, just meeting a person, you already are engaging in one of the first pillars of their diagnosis, which is a social communication deficit. It's the same as if a person who is in a wheelchair, you would see that person and go, oh, well, this person has mobility issues. They're going to need access to this building, whether it's, with an elevator or we need a ramp. That's your mindset immediately goes to that. We need to think about that for a person who's on the autism spectrum, who is on the autism spectrum. It is one of the hallmark characteristics of autism is that there is a persistent deficit in social communication, which means you and I are talking with somebody, we are coming in contact with that person's disability. And then the second part is the restricted repertoire of behaviors, interests, activities, and it can manifest itself a lot by repetitive or stereotypical motor movements. The insistent on sameness can be hyper or hypo reactive to sensory stimulation, can be really highly restricted to their routines and fixated on interests that may seem abnormal to other folks. And so these are really some of the characteristics that we look at specifically that helps a neuropsychologist or a psychiatrist or a neurologist make the diagnosis of autism. So the history and causes. If you haven't heard or who Temple Grandin is, Temple Grandin is really the ambassador to autism that has been speaking on behalf of autism for probably close to 60 years. I believe she's in her late 70s now, and she has written a lot of these books. There was also a movie made of her, Temple Grandin, and Malia, I can never remember the actress's name.
Claire Danes.
Claire Danes.
It was a really good movie. Yeah.
Yes, and she actually received an Oscar for it. So if you haven't seen Thinking in Pictures, My Life with Autism, is the Temple Grandin story. It's a well worth time to spend watching that. And one of the things that I always have appreciated, she's just very frank, very concrete about what she says is, the history and causes. If you've seen one person with autism, you've seen one person with autism, meaning each and every person has a different way and how they land on the autism spectrum. And I'm going to be talking about that here in just a minute. So what is autism? Well, we know that autism is a developmental disability that is lifelong and typically appears within the first 3 years of life. That doesn't mean that they're going to be diagnosed within the first 3 years of life, because there are obviously a lot of folks that may have had multiple other diagnoses, such as ADHD or obsessive compulsive or a lot of other things. When it comes right down, it circles back and says, oh, this person actually meets the criteria for autism. Autism is a neurological disorder that affects the functioning of the brain. It's not a social emotional, or it's not an emotional psychological disorder or mental illness. It is a neurological disorder. It means how the brain is wired. It's wired differently. As a matter of fact, there have been a lot of tests that have shown through PET scans when a person, a neurotypical person, is shown an object, that it shows and it can track the lighting of the brain of where all the connectedness is, like a picture of their mom. And another person who is neurodivergent or autistic, they could show that person their picture of their mom and it would only maybe light up in one or two places in the brain. It is the way the brain is wired. And to help people understand, it's like if you go into a building, you keep on flicking the switch and nothing turns on. Well, you have to find that switch somewhere in the building that works, because not all that is going to meet how the brain works. And there's no physical attribute or blood test that really differentiates autism from a person, let's say, who has Down syndrome. Down syndrome, you can do blood work that shows the chromosomes, that there's an extra chromosome, or that there are microcephalic or hydrocephalic, or there are things that maybe sets apart a person from another person. That is not true for those who have autism. That people with autism may communicate, interact, behave, and learn in ways that are really different than most people. So when we talk about autism, it really is a spectrum disorder, and it exists on a continuum. And I don't always like to use, I don't like to use the words mild to severe, because it doesn't really reflect how a person, how their brain works, because it's going to look differently. I'll get into that in just a few minutes here. But it can and often does occur with other developmental disabilities, such as an intellectual disability, like what I talked about with my son who has autism and an intellectual disability. They have deafness, be blind, have Down syndrome, bipolar, cerebral palsy, and the list goes on. It can co-occur with any other disability. The thing to be of note is that autism is a pervasive developmental disability, that it impacts all aspects of that person's life. So we need to focus on the person's autism. We need to focus on the person with autism as their primary diagnosis, and use support strategies that help them help them learn, help them communicate when we address their autism first. It has significant differences from an intellectual disability. Just as I said, I mean, for my son who has autism and he has an intellectual disability, but other people, I mean, like Malia had described her daughter who has ADHD, but she doesn't have an intellectual disability, but she certainly has autism. And like I said, you might even have a person who has ADHD or an obsessive compulsive disorder or an anxiety disorder. Those are more of a mental health condition that autism is the pervasive, and then you have the co-occurring disabilities. So here is, really one of the things as, and I know we have folks that are from all ages that are attending here tonight, I should say. Let's come back here. Is that because we have either people that are in school, they're in preschool, this is that we have people that on the spectrum will have communication and language problems, social relating, judgment, perspectives, and even understanding boundaries, can have restricted repertoire behaviors, can have some cognitive differences, being literal and concrete, having difficulty with organizing and sequencing. Some of that has to do with executive function, scattered or uneven development. So you might have splinter skills that somebody's really good in numbers or routines, and yet doesn't have critical thinking or problem solving abilities. So we can't make assumption based on one area over another. We have to understand where that person and how their scattered skills really manifest and how we can support them. And then we have people who have sensory issues, over or underreactive, and that could be one day over another day. It doesn't mean that they are continually in that state of sensory arousal or lack of arousal in the sensory processing. So here you have autism, and you have in the dark blue are basically the dyad of impairment, the social communication deficits, and the restricted repertoire behaviors. What you see in the other circles are co-occurring or associated neurological symptoms with autism. So it could be the intellectual disability, language disability, seizures, aggression, trauma, hyper or hypoactivity, attention, anxiety, mood, sleep deficits. And then we can have what is associated with physical or physiological symptoms such as GI disorders and immune dysfunction. So it oftentimes autism does coexist with other diagnoses, and it is really a good diagnostician that's going to be able to differentiate one from another and be able to give the right supports and understanding of what a person may need. So, and actually I changed this on my training last week and forgot to do it here, but the CDC, and actually this was in 2020, the CDC just last month in March of 2023 increased that it's 1 in 37 children will be born with an autism spectrum disorder. And that is, that's a lot of people. That's a lot of folks. And I can tell you although the diagnostic criteria has had some changes to it, diagnostic criteria has also eliminated people from this. But when my son was born, the incidence of autism was 1 to 2 in 10,000. 1 to 2 in 10,000 births. That was 39 years ago. And you're looking at what it is today, it's 1 in 37 children are born on the autism spectrum and with co-occurring diagnosis as well.
It says 1 in 44 on our screen.
Yeah, and I said, that's what I said. I didn't update this, but in March of just last month, March of 2023, that is now 1 in 37 children are born on the autism spectrum. This was in 2021. Now in 2023, as of March, just last month, it is now 1 in 37. So what is autism? Autism is now, it's considered 4.3 times more common in boys than in girls. I always like the 0.3, like what? I mean, you're gonna slice somebody up, but the interesting component to this is oftentimes girls are later to be diagnosed with autism because socially in our culture, girls are often shy. And it's just kind of attributed to this person being more shy rather than they are isolating and are socially not able to connect with other folks. So hopefully that's going to start to change because there's more of an understanding of what that is. Autism knows no boundaries and it's been found throughout the world and all families of racial, ethnic, social backgrounds. It's a non-discriminatory type of disability. Everyone will be affected by autism. The DSM-5 currently recognizes 5 different subtypes to autism. So these are some of the subtypes that were identified that weren't part of the DSM-4 that the DSM-5 really focused on, which is autism with or without accompanying intellectual disability, autism with or without an accompanying language impairment, association with a known medical or genetic condition or environmental factor, autism that could be associated with another neurodevelopmental, mental, or behavioral disorder, and then autism with catatonia. So these are all in the diagnostic statistical manual that the diagnostician is going to be looking at as they do the coding and really starts to define how this person, how they define their autism and what services and supports would really dictate what that diagnosis means. So the cause of autism, that is, the $10 billion question is researchers are investigating really a number of theories, including, the link between heredity, genetics, medical problems, viruses. And so, why does research take so long, for heaven's sakes? What we do know is that what therapies and services work best is still what research is still trying to really figure out. Because, as I told you that Eugene Buehler in 1911 coined the term autistic. Then in the 40s, that Leo Kanner and Hans Asperger identified more of the classic autism or autism with an intellectual disability versus Hans Asperger, hence the name Asperger's, for more individuals without an intellectual disability, that it wasn't until really the 1990s, within 30 years ago, that really attention was brought even more to the forefront. And that was just by more clinical information about autism that just started to kept reappearing and reappearing, that especially in I would say birth to 3 and 3 to 5 programs, and especially those associated with colleges or universities, that they were starting to really identify that there were children that really were under the definition of what Leo Kanner and Hans Asperger had actually identified. So research, really starts with, the hypothesis, and then they read what other researchers have done, and then they ask if the hypothesis makes sense, and then they start looking for more and more information. And I can tell you, within the last 20 years, there has been more information and research done on autism collectively just in the last 20 years than there has been over the last 100 years. So it is profoundly something. Actually, if you're looking at 1 in 37 births, there needs to be more attention to this. So we know that there's longitudinal studies that show or follow a group of people over a period of time. For example, researchers could follow 500 people with autism, and in which they actually do. And then there's an experimental study or a clinical trial that involves changing one thing. Maybe it's a medication that they use, a placebo along with a medication, to see, does this impact or help with insomnia for a person with autism? Well, and then there's the research rinse repeat. Is researchers may want to repeat the experiment to see if these results really are true, and if they, like for Leo Kanner, he had 11 individuals. Well, that is a very small group of people. They need to expand that so that they can get a larger group of people to see if they get the same results. And so there is that repeating process. And there have been, well, I know at least in the University of Washington, there is the Autism Center there, that clinically they do diagnosing. They have the children's clinic, they have the adult autism clinic. There's a lot of information that is there that wasn't there even 30 years ago. And so my son, being in his late 30s, that wasn't available. I mean, that just wasn't even something that we really even through school. It was really towards the end of his educational career that I started saying there needs to be something else that's going to help him. But I'll get into that here in just a few minutes. Spark is a research program that is actually, people can enroll in it independently. They answer study questions, and what the researchers do is they study the participants, their answers, the biology and the genetics of autism based on information that is provided by people with autism or families, so that they can they're getting more information about autism a lot faster than they had in the past. So what we do know for heredity and for genetics, patterns of autism or related disabilities in families supported a genetic basis to autism. And I can't remember who had mentioned that, there was somebody who takes, who has a family that has 3 individuals or 3 young children that are part of a program. I can't remember what. I mean, I just know that you had 3 people that you were working with. At any rate, that's not an unusual condition. that there will be more than one person in a family with autism. So they do know that there is genetic condition. But what is happening is that what they don't know is what gene, and that there isn't just one gene that has been identified that's causing autism. There are basically, there are mutations, there are irregular segments to genetic codes that all could be an inherent process still trying to figure out. The brain is an interesting organ, and so trying to figure things out really is a process, and it's going to be a while before we understand what that means. It also appears that some people are born with a susceptibility to autism. Researchers have not yet identified what that single trigger is, because there have been children that are born neurotypical, that they're meeting all their milestones, and then anywhere between 12 months to 36 months, they may lose their language. A child that was happy and socially engaged is now not. So they still don't know what that trigger may be. And that's something that research, again, is looking into. Researchers have known that genes contribute to autism since the 70s, and which really, this was at University of Washington, that identical twins, they were researching identical twins that had autism. And so it's sometimes they were fraternal and sometimes they were identical, but it is really in decoding the DNA decoding that really has evolved over, obviously, just this past decade for DNA, that they're getting more information. Like I said, possible clusters of unstable genes in the brain development, possible gene mutation. SYNGAP1 is one of those that I'll get into in just a moment. Investigating problems with pregnancy or delivery, environmental factors that could include viral infections, metabolic imbalances, and exposure to environmental chemicals. So, just looking at this page, and it would be like, oh, heaven's sakes, how would you be able to pinpoint it to a specific thing? What we do know is that there are different things. There is a connection to genetics. There is a connection to autism in the family, and or that each person will have autism and experience it in a different way. So this is my story about autism with my son. Is first off, he wasn't diagnosed with autism until he was 7, because there weren't diagnosticians in the community that knew about autism. He was considered having a developmental disability. He had an intellectual disability, but I could tell you with my early intervention programs that he was involved with, it was like, good golly, he just does not fit. He doesn't fit. He doesn't act like anybody else that I've ever come in contact with. Not to say I didn't love him dearly. I was just obviously worried. So not having him diagnosed until he was 7, we were playing catch up basically, because he didn't have early intervention services. And actually that wasn't even a thing until the 90s. And so he was well into his academic career. And then it was in 2009. Now we're many years into his lifespan. And in 2009, he going to his neurologist, because he has what is considered an intractable seizure disorder, meaning he has multiple seizures throughout the day. He's on 4 anti-seizure medications, and he has a vagus nerve stimulator, and yet he still can have drop seizures, and a whole host of other seizures that we have been able to keep them from escalating until he's in static epilepsy, that at least he is not that. But that being said, his neurologist recommended that we have a DNA, we have a genetic testing. And I was like, why? I mean, at that time he was in his mid-30s, and I thought, what is that going to do? And there are types of epilepsies that can actually have they actually have gene therapy that they can reduce and sometimes eliminate seizures based on the type of gene associated with that epilepsy. Unfortunately, Michael didn't have that, but what we did discover is that he has what is called SYNGAP1. It's a related non-syndromic intellectual disability that has been identified and suggesting that it may represent one of the most common causes of intellectual disability and autism. The use of genomic sequencing has dramatically increased. And so as of just this first quarter of 2023, there are only 1,256 people worldwide with SYNGAP. Michael is one of the 3 oldest in the world. Although they feel that this, if we were to go through and test adults at this point, we would probably find there would be a lot more people with SYNGAP than not. And SYNGAP, basically, it has that there is 100% of patients have a pathogenic mutation. They can have between a moderate to severe intellectual disability. People with SYNGAP1 have a high pain threshold, and they also have low muscle tone. 85% have epilepsy. 50% have characteristics such as hand flapping, sensory processing, self-injurious behaviors, obsessive compulsive behavior, poor social development, but no association has been found between autism and the severity of the intellectual disability, or because the location of the mutation gene and where it might have the disruption in the genetic chain. What we do know is it manifests within the first to second years of life. It also impacts motor delays, such as, or I should say, motor milestones, so that there's delay in sitting. Unaided is average of 12 months. Walking unaided is average 2 to 3 years. Motor coordination issues like axial and facial hypotonia, and ataxia and gait instability, and then strabismus, which is basically a lazy eye. So there are, certain components. And so now, of course, there's only 1,200, about 1,300 people, respectively, in the world. There's a lot of research being done on this because this is a breakthrough. So we know 75% of SYNGAPians have severe behavioral problems like hyperexcitability, anxiety, aggression, oppositional behaviors, tantrums, and self-injurious behaviors, severely impacted play expression and receptive speech development. A third of people with autism remain nonverbal after 5 years of age. And verbal individuals with SYNGAP range from single word to brief sentences. That would be where my son falls into. And then there's the milder phenotypes have been observed in people with mutations 1 and 4 as compared to more severe phenotypes in exons 8 to 15. So there are some folks that may have low muscle tone and have epilepsy and yet don't have an intellectual disability. Matter of fact, you wouldn't even know they had any sort of developmental disability, and yet they could also be a person who has SYNGAP. 60% of people with SYNGAP also report sleep disturbances. Again, something that's very, it's a typical problem for a lot of people with on the spectrum. And sleep management is suggested. A lot of eating difficulties, oral aversion, or oral hypersensitivity are common. A high percentage of people suffer from constipation, and a small percentage of patients with SYNGAP also have G-tubes. So that brain-gut relationship, not only for a person with autism or a person with autism and a SYNGAP genetic disorder, GI issues is a very common thread through all of this. But whatever the causes are, we know that children are born with a disorder or born with the potential to develop it. It's not about bad parenting. It's not a mental illness. And though there can be co-occurring medical diagnoses, that we know that up to 42% of people with autism have an anxiety disorder. In contrast, that's 3% of children and 5% of adults who are neurotypical have an anxiety disorder. So almost half of people with an autism spectrum disorder have an anxiety disorder. And I mean, for those who are parents that year, I don't know how many times, and actually, I remember what training we did, Malia, but we were talking to these families, and it was just this constant stories of families being, told that, well, if you would just spank your child, if you would just, give them more discipline, if you would just X, Y, and Z. And it's not about bad parenting. It is that these kids, these individuals come with a separate set of directions. And it is not about discipline, it's about teaching. It's
They don't
about
give you
helping-
those, they don't give you those directions at the hospital either.
I know, right? Good heavens. Exactly. And that we know that people, neurodiverse people or autistic people are not unruly people who choose to misbehave. And that we know that there is no known psychological factor in the development of the child to have shown to cause autism. And that was something that was referred to many years ago, really between the 40s, the 50s, 60s, and 70s, up until actually, and there's some still other countries in the world that still think that autism is caused by their parent, one of the parents, typically the mother, of being cold and unfeeling, hence the name refrigerator mother. So how autism differs from, say, an intellectual disability is, despite there are some similarities between autism and an intellectual disability, there are several important differences, excuse me. Autism cases vary in IQ with both below and above average test results. In fact, it's really common for people who might have significant autism to have an IQ of 70 or below. So that's a person with autism and an intellectual disability. While some people may have really high IQs, while there's also that small population that are considered at genius level or savants. This differs from people with intellectual disabilities who all generally have an IQ of 70 and below. That part between 70 and the average of 100, those are people that could have a learning differences, can have, they just don't meet the criteria for an intellectual disability. According to Spectrum News, the medical establishment once considered autism and intellectual disability to virtually be inseparable. But we know that in 1980, as much as 69% of people with autism diagnosed also had a diagnosis of an intellectual disability. It was by 2014. Now, mind you, this is now that's 9 years ago. The figure for dual diagnosis has declined to 30% as researchers had sharpened the diagnostic criteria for autism. So when people are saying, well, they must have just gotten better with diagnosing, they must have more, why there's an increase in autism. Well, again, it is to understand that the researchers have sharpened the diagnostic criteria, and that with the rollout of the Diagnostic Statistical Manual edition 5 really sharpened that diagnostic criteria, which eliminated a lot of people that had been considered autistic in the past. How autism differs, again, from an intellectual disability is reasoning, problem solving, comprehending complex ideas, and other cognitive skills. So it's diagnosed, its diagnosis is based on the intellectual quotient of 70 or less, as I had indicated in my last slide. Autism, on the other hand, is defined primarily by social difficulties, such as the diet of impairment, that is the social communication issues and repetitive behaviors. the Center for Disease Control, that was right, as of the most recent prevalent study conducted by the CDC, that they actually had people, rather than having the diagnosis of the ICD-9 come in from doctors, they actually did the study with children in, I think it was 13 different states, that they indicated that there were 38% of children with autism had an intellectual disability. Of that, 24% of children with autism were considered in the borderline range, and an IQ of 71 to 85, and then 38% had IQ scores over 85, considered average or above average. As I had mentioned, a higher proportion of females with autism had an intellectual disability compared to males. And again, that is one of those things that they are really coming to an understanding that females are, in our culture, are considered, they're just shy. They're just horribly shy when they are missing those diagnoses. And that's a whole other training that I would do on that, and of which I have. But 46% of females with autism had an intellectual disability compared to 37% of males, which I find it interesting. Like I said, that autism is 5 times more prevalent in males than females. There's a missing link here that should say that, why are we missing so many females? And I think that accounts for folks that are not being considered. And that difficulty to diagnose girls is that autism, affects boys, right? Officially boys outnumber girls 10 to 1 for high functioning. But in fact, most everything we know about autism only comes from studies of boys. There is no study from girls. But now some scientists are making discoveries that challenge common assumptions about autism, girls, and gender. Spark, which is the Simon-powered autism research, began with questions that have really dogged researchers: is why are so few girls diagnosed with autism? Are girls simply less susceptible? Do girls look different? Does autism look different in girls? That's really the question, and making it harder to detect the diagnosis. Growing number of studies suggest that girls with autism, particularly those without an intellectual disability, may be hiding in plain sight. Like, they appear to have less severe symptoms than boys, and are better able to master social challenges in school. But the 11 signs of autism in girls relies heavily on other children to guide and speak for them, are passionate, have restricted and specific interests, usually sensitive to sensory challenges, more sensitive than even boys. Conversation is restricted to limited topics of interest. Difficulty moderating feelings when frustrated. Unusual depression, anxiety, and moodiness. Difficult making friends and keeping friends, often described as quiet or shy. Unusually passive. Difficulty with social communication that increases with age. And then a lot more women with autism or girls have epilepsy in that. So according to the Interactive Autism Network, if you haven't checked them out, they have a lot of really good information about autism, about across the lifespan. It's called IAN, the Interactive Autism Network. And one of the things, their online autism research community, and that they have noted that other girls with milder forms of autism are diagnosed later than boys, possibly delaying really interventions, which is unfortunate. And then what we know is that there are some that may not be diagnosed at all. Without an accurate diagnosis in the teen years with autism, appear to oftentimes suffer from anxiety, depression, more commonly than boys with autism, or typically developing girls. Sorry, I've got a dog barking. Ava, go. No.
While we have this break, does anyone have any questions? I can tell you that my daughter wasn't diagnosed until she was 7 because maybe because of those, it isn't often seen in girls. And she was highly verbal and had a high IQ, so could mask it. But yeah, she definitely she definitely does have it. She can spin for days.
And it's interesting, of all the customers, patients, clients, students that I have supported, I can tell you I have only had, literally, I could probably count on 2 hands how many girls I have actually worked with. The rest, and literally 100 or more adult males and children, all are with autism, are all boys, are all males. So it really is, it's sort of like, you know, where cardiologists are figuring out that, you know, women experiences, you know, a heart attack much different than a man. Women, because they only did testing on men. I mean, it's like, oh, go figure that men and women can be different. Well, the same thing has to do with autism as well. And thank you for my my interruption there, as my husband took my barking dog away. She found a squirrel outside. So we know that a person with an intellectual disability can oftentimes perform slower from their from other peers. So they have what is called a global delay sometimes, oftentimes, and that they will have a delay in one area as they would in every other area. As conversely, for a person with autism, they kind of look like an EKG. So they might have really, you know, a splintered skill in numbers, and yet they can't put their own shoes on. They might have word recall and recognition, but they don't have reading comprehension. So it can look very different for each person. And so when you look at a person with autism and an intellectual disability, you can tell that they are different, and they need supports that are different. The splinter skills in autism, it can be particularly tough to separate the splinter skills from understanding, because someone's like, I don't get it. If, like, I think I told this story last week, I have worked with a young man who he's in a transition program, and he can do binary equations in his head, but he cannot transition from one classroom to another independently. He can't put his shoes on the right foot correctly. So the assumption that it's just like, well, I don't get this. He's a smart guy. Why can't he put his shoes on? Well, it's not how smart you are, it's how you are smart. And he has a splintered skill in math aptitude, but he doesn't have critical thinking or executive function, which are completely 2 different things. So it's, like I said, sometimes it's hard for some people to really kind of wrap their brain around the fact that their brain works different. And in one area, a person can have this incredible aptitude, and yet they're not able to perform in another. We have to understand that and understand how that person experiences all the characteristics of autism, because each and every one of them are going to have a significant and broad ranging attributes from anybody else. Like, for example, hyperlexia, the ability to decode words, is a common among children with autism. And so there's a mindset that, oh, they can read, but they don't understand that actually it's not that they can read, it's that they are decoding words, but they don't have comprehension. What does this mean? And then similarly, a child with autism may have extraordinary memory and have a rote memorization of that repetitive use of known phrases, that they can repeat paragraphs memorized from books or videos, but oftentimes they don't understand the significance of it or what they're trying to what it even means. A child who can recite his alphabet backwards and forwards by the age of 3, but is unable to understand what letters are even used for, or a girl who can recite the entire script of Disney's Beauty and the Beast, but is unable to answer any questions about the characters of the story, or a man who can tell you the stats of the Major League Baseball players, but knows nothing about how the game is played and no ability to be able to follow the game, even if you were to watch it. Roughly 25% of people with autism speak few or no words. That, unfortunately, a generation ago, the figure was close to 50%, and that really is because of the dawn of early intervention services. That understanding that the recognition that children with autism, as in any child, but specifically those with autism, having early intervention services have helped children develop language more so than they ever had in the last 20 to 30 years. What we do know is one of the primary success stories of early intervention is that they promote language development. And although Helen Tager-Flusberg says that nevertheless, she says, there are clearly individuals who are diagnosed early who have access to high quality intervention and still fail to acquire spoken language. And just because a person does not acquire spoken language does not mean that they cannot communicate. And so there's that understanding, because even spoken language, there is a lot of motor planning. There's a lot of executive function to be able to bring up word recall, to be able to put it in a way that they're able to express themselves. That acquiring spoken language is a very difficult process. And then you add onto it a way that a brain is wired differently. It doesn't always work out. Nancy Brady, she said many minimally verbal, nonverbal people with autism are diagnosed with comorbid diagnosis of intellectual disability, but some people who could not speak actually read fluently and comprehend and know, that they're very, very, actually, I can, earbuds just went kaplooey, is that very intelligent, and yet they cannot speak. It can be difficult to tell how intellectually impaired a person may be, because if they can't speak, then they may be misunderstood them. And when we assess them and assume that they are much more impaired than they actually are. And that's been the unfortunate reality with a lot of people. Because a person who's nonverbal, again, we undershoot them, not only in in learning, but also with medical care. If you have somebody who's a poor historian, we often just kind of brush it off because it's hard. And when you have somebody who struggles with the ability to communicate, we are social people. And not only that, we like things quick. We like things fast. And that isn't always the process for people with autism. Is there are some people who have receptive language that for them to process that language can sometimes take anywhere to 2 to 3 seconds to 30 seconds. And so for you to understand where that person is in their processing is going to be an invaluable gift to them. So hopefully you have a better understanding of autism in the significance and how it is different than an intellectual disability. So now we're going to get into really kind of the characteristics of autism, how they're identified and then defined in the characteristics of autism. And I'm going to be talking about cognitive differences, different learning styles, sensory processing difficulties, difficulty with social relationship, need for sameness, social communication difficulties. And again, this can all be for a person who doesn't have an intellectual disability to a person who has a significant intellectual disability. It is at everywhere in between.
cognitive difference that we know that most people, autistic people, focus on detail and are unable to see the whole or how things fit together. They have difficulty integrating information. So that receptive language is one of those things, is I'm trying to integrate that information, extracting meaning and distinguishing among relevant details. So if you've ever been at an airport and all of a sudden over the intercom, I don't know what it is. I usually bring up airports because I find it I think it's a very stressful place. I don't know if I feel like I'm going to be late for a plane. I'm going to miss the plane. I don't know. And now going, not now, but, over the last 25 years of going through TSA and doing all that. I mean, there's this, I don't know, for me, it's a sense of anxiety. So that just when something comes over the loudspeaker, I'm like, what did they say? What did they say? And my husband will go, well, they said blah, 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 blah. And it's like, my gosh, why can't I hear that? It's because my anxiety is so high. My ability to process and extract meaningful information is gone. I need to have things that are written so I can read them so that I can comprehend them better. People with autism, their eyes work better than their ears. People with autism are typically strong visual learners and have more difficulty processing language. And yet 99% of how we instruct children and how we support adults is through verbal language. And we expect them to be able to process information because after all, they can hear, right? Wrong. It is they can hear, but it's the ability for that person to decode to their receptive language is having to process what is being told to them, and that they need to distinguish that information that's important. So people with autism have difficulty organizing their thoughts, tasks, and process. So when you give a child, say, a three-step direction, don't be surprised if they only do step one and the last step, and that they forget the middle step because they have not been able to organize that. Sensory difficulties, that's difficulty with sensory modulation. So touch, auditory input, oral stimulation, olfactory, proprioceptive, vestibular, and then I'll also be talking about interoception. I'll get into that here in just a moment. So getting into more of the details, most people with autism struggle with the complexities and the social nuances, such as making friends. That takes a lot of executive function to really start, I'll go back here. When we look at, when we look at difficulty organizing thoughts and processes, if you have somebody now who's talking with you and they're to make a friend, typically you try and find out what are the commonalities that you can share. As we learn and that we are social beings, and being around people, the social nuances, the social rules, all those, just through exposure, even playing with other children, can teach social rules and social hierarchy in a very non-instructive way. That is through exposure, which is different than a person whose brain is neurodivergent. That making friends, sometimes they don't know how to, but it's a skill that we can teach. And it may that difficulty initiating conversation and volunteering information. I mean, that too can be taught. Then understanding somebody else's perspective, like theory of mind or mind blindness. What does that mean? That, Malia might be thinking something completely different when we start talking about, let's say we're going to talk about, we're going to present some more trainings. And I'm thinking, well, I've got this whole list that I want to do. And I start coming at her with this information, and Malia's like, well, that's not at all what I had in mind. It's like, oh, I didn't process in my head that, oh, she might have something else in mind. That's where collaboration and being able to talk about things is that we need to get a perspective from somebody else's point of view. When somebody doesn't recognize that, that is called mind blindness, or theory of mind. Being able to recognize that a perspective from somebody else's point of view is something that is related to that dyad of impairment of social relating. Often children with autism relate better to adults because they tend to be more predictable. They tend to slow their words down. It's not that people with autism do not want to relate. Oftentimes they relate in different ways. I'll take my son, for instance. His way of relating, when people think of, we want Michael to be socially community minded, to be able to be in the community. Well, he has really high social anxiety, but his way of participating in a social way is to be in proximity to people. It doesn't mean that he has to be at the table with somebody else or anybody else. As a matter of fact, if he is, like we've done person-centered plans for him, that he prefers to sit away, but he's listening to everything, and that he will answer a question. Sometimes just like, well, you are listening, for heaven's sakes. And it's not that people with autism don't want to make friends. It's often they don't know how. And knowing and developing a relationship with a person with autism is highly imperative. Relationship development is the primary, should be the primary focus for anybody in their life, including the family, friends, teachers, respite care providers. I mean, the list goes on. It is that we take time to build that relationship with that individual. Without it, then what we're doing is just, we're taking somebody else's point of view, or what we want then is for that child to be compliant. And let me tell you that those are words that really, those are things that can get my blood boiling, is when somebody seeks this person to be compliant. We need them to stop their behavior. And it's like, all right, so let's look at what it is that that behavior is communicating. So knowing and understanding that person and their relationship, you're going to understand that all behavior is communication, and there is a function and a value to that behavior. We know that the human interest in social development, there's lack of social reciprocity. That empathy, which is that oftentimes that perspective taking, the awareness of the perspective of others. It doesn't mean that people with autism don't have empathy, because they do. They don't always recognize that somebody else has empathy. They may have difficulty developing peer relationships, that they don't always seek to share enjoyment or in interest or achievements. And matter of fact, I hear this often, that children come home from school and their parent will say, "Did you have a good day?" Yes or no. I mean, just, well, tell me about your day. "I came home on the bus." And it's like, well, what happened the rest of the day? Because they can't organize and historically report everything that happened during the day. They will just typically tell you either the first thing that happened in the day or the last thing that happened in the day, or something that was significantly stood out. And then that becomes almost a perseverative issue that eliminates everything else. There is the communication deficits of having the lack of conversational reciprocity, whether it is listening to someone and they don't understand when it's time or when it's their turn to talk, or conversely. And I've worked with a lot of adults that, they will talk about something. To the point of like, I need you to stop and let me have a turn, because they don't understand that communication and friendship is a two-way street. And that's what reciprocity or reciprocal. Difficulty understanding nonverbal cues. There is so much of our communication that we use that is nonverbal. If I start doing this and really, and my voice gets really loud, you're going to read something into it that, boy, she's getting really excited. For that person with autism, they're not always going to recognize that. or they're not always going to recognize that you're pointing to something. They'll just continue to talk with you. And you're like, do you see where I'm pointing? And then they're like, oh, are you pointing at something? So the nonverbal gestures and the nonverbal cues, the facial gestures are things that oftentimes are missed for people who have autism. Can be very literal and concrete interpretation. Have difficulty with control, volume control, cadence and intonation, especially around children, that they have sometimes it's what we call the loud and louder. There's not the, oh, what does it mean to be quiet? It's a concept, and teaching a child about what a concept is, you know, especially if you're teaching a person who is a literal concrete thinker, that you need to speak low, and then they get underneath their desk and they start talking again because they're speaking low. That's a literal concrete thinker. And they don't understand that there's a control, and there's a way that we can teach a person what does it mean to have the volume control. And it's not, we need to speak lower or we need to have our inside voice, when in fact we are inside and I am speaking. So those are some of the things we can, to be able to teach people concepts of some of those just things that you would inherently think, why are they doing this? And then after you look at what they're doing, it's just like, oh, for heaven's sakes, that's a literal concrete interpretation. May have repetitive use of known phrases, functionally or non-functionally. I can tell you one of the things my son would, and he still does, and one of his favorite movies is Wizard of Oz. And if he's getting upset or anxious, especially in a social situation, where he's having to wait any period of time, he will look at me and he'll say, I'm melting, which that means, oh my gosh, you know what? We've got about 5 seconds to get out of this place, because he is using that. And that is a known phrase that I know what the meaning behind that means. There are oftentimes children who have very large vocabularies. Again, a child that can decode a word, but still not comprehend what that word means. May have difficulty answering open-ended questions like, so what would you like to have for lunch today? Rather, they do better with choices. So we're having lunch, which is a statement. The choice is peanut butter and jelly or chicken nuggets. So you have given an explanation and you have given choices. That's how children really do better with answering questions. And I always hear people say, well, I gave them a choice. And it's like, no, you asked them a question. We need to give them choice. And it usually needs to be in a very visual format. A child understanding idioms and sarcasm can be very difficult. And then, Malia, I just have to say, because I told my husband, I thought I did a training last week and I had mentioned that my son is 39 years old. And I said, well, and that he's 39, that I had him when I was 12. And there was nothing. There's no, I said, I'm kidding. That was a joke. And it was like, oh, for heaven's sake. I mean,
But you told that joke to a bunch of autistic people.
I know.
So-
I mean, that was my bad. Exactly. And I had to laugh at that. It was like, for heaven's sakes. And I thought, and that would be the other thing, that social piece is like, that wouldn't really be something I would want to share socially, that I was 12 years old when I had my first child. I was 25 when I had him, but that's, now you can do the math and figure out how old I am. But anyway, that was one of those situations that was just like, oh, for heaven's sakes, my sarcasm does not always do me any good. And idioms like, like, oh, kill two birds with one stone. Or I've had people say, oh, why do you want to kill two birds? It's like, oh, no, that's not the point. I want to get, it's like, oh, never mind. I mean, the idioms are things that are inferences. They infer a situation that a person who is a literal concrete thinker will not get the inference. And so we have to give them a very literal concrete answer. And or there are kids or people just across the spectrum that use echolalia. And echolalia which again is one of those things with working with job coaches and some residential providers that, you know, like Tim went into Joey's room and it's like, Tim, you don't go into Joey's room. That's Joey's room. That's not your room. And they're just like, yabba, 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 yabba. And it's just like, Tim, you need to tell Joey you're sorry. And Tim looks at Joey and he says, tell him you're sorry. I'm sorry. Do you think he actually understood what I'm sorry is? Or he understood why he needed to say that? And that what he was doing is being echolalic, and that he was not answering, or he was not giving the gesture of being, of saying he was sorry. He was just repeating. And so we have to be very cognizant of when echolalia is being used, and by providing choices, especially in a visual format, that's going to help eliminate a person's use of echolalia in sometimes, like I said, ineffective or non-effective ways. That need for sameness, the unusual resistance to change, that a person with autism develops a routine quickly. They are first-time learners. So we want to set it up the right way the first time. They don't learn from their mistakes. And I often have people say, well, we'll get into a routine. It's like, no, you need to set up the routine for them right off the bat. And so that we want to build on that, because that is one of those, although people say that is, you know, it is one of the diagnostic diet of impairment. It is an impairment that we can use to the benefit of the individual by providing them that routine that child or that adult is going to be able to have independence with. They may need to repeat something before they move on. A young man that I was working with this morning, he did that. He had one of his tasks was he had to wind up electrical cords on one of those electrical cord holders that rolls up, and you have to hold it in one way. Well, he kept taking it off and putting it back on, and taking it off and putting it back on, because he needed to figure out how to do this, and he wanted to repeat it so that he got it and before he could move on. And then you may have people who have special interests and that are highly developed. Again, the young man that I was thinking about this morning, who is functionally nonverbal. That being said, he talks so fast and he is multilingual. He speaks English, Vietnamese, and Canton Chinese. Mom's the only one that can understand him because he talks so fast. And she said, oh, he said blah, 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 blah. And I'm like, oh my gosh, that's crazy. But what he likes to do is that he does at least a 1,000-piece puzzle daily. That is his thing. He highly developed. And one of the things that we're looking for him as a job is I'm having him put power cords onto basically it's a USB cord that goes into a pen light that needs to be recharged, but he's got to untangle all these cords, and he just loves picking and pulling and picking and pulling. Now I can tell you, if it were my son, he'd be like, yeah, I'm done with this. It's really looking at, that person's special interests. And for this young man, I mean, everything's a puzzle for him, a jigsaw puzzle, or a puzzle to figure out, how do I get this string apart? There's a knot in his shoe. He's got to figure out and pull, and then he's pretty incredible. So back to the comment that I made earlier, that all behavior is communication. We can't extinguish a behavior without understanding what that behavior is communicating. Does the person have a functionally efficient way to communicate his or her wants or needs? And if you're expecting compliance, don't be surprised if you get the kickback of behavior. Because if you're looking for compliance, that person actually, the function of behavior is either to avoid or to obtain. And if we don't understand that, then if we're asking for compliance, what happens is you're going to have either some pushback or somebody who is going to be compliant all the time, that we can set them up to be a vulnerable individual in the community from always saying yes and always being compliant. We need to think, why does this person need to engage in this challenging behavior to get their needs met? I mean, it could be, a sensory dysregulation. It could be that the whole environment is sensory overwhelming. There are so many things, just as I have just gone through, that we have to meet and to have the understanding of how this person experiences their autism and how can we help them meet those needs, which could be, this person needs to learn how to self-regulate, or we can help this person by giving them, like for my son, when he was younger, one of the things that he would do, he would get so upset, he'd do a lot of self-injurious behavior. And if you got near him, he would become very aggressive. And the one thing that we learned was, one, keep your distance from him, but put a wet cloth, a cool wet cloth near the table by him, and just point to it and get his eye, that he could then wipe his face off. And it was cooling and it helped him. And that's still something that we use to this day. And so there are things that we can obviously provide for a person so that they don't have to get to that point of just losing it before they get their needs met. So like I said, we need to step back and think, gosh, what are they trying to say? It's our job to help them express themselves in a way that they can learn how to get their needs met without needing to act out. I can tell you, is this easy to do? Not always, but it certainly is worth the effort. And it is certainly worth the effort, especially when you take fastidious notes and you take data so that you can say, I could tell that the environment was really loud. Oh, and it's more than just the ABCs of doing a behavior, the antecedent behaviors and consequences. I was like, what the heck? It is really looking at the characteristics of autism. What's the environment? What was the relationship to the responsibility or the initiation of this person engaging in an activity? Is it a liked? Is it something that's a liked activity? Is it something that the person is interested in? Because people that with autism, we need to find what's intrinsically motivating for them to entice them to do something rather than just looking for compliance. Avoid power struggles. It is a lose-lose scenario. Power struggles you will never be the winner. It is either being with the person, sitting with the person, putting yourself in a position that you are out of harm to help this person be able to relax, because when they're in that basic crisis, there is no teaching being done. There is no learning being done. And I can tell you, for as high as that person is in the power struggle, so is that teacher, so is that respite care provider, whoever it is, they're following along on that trajectory of basically the iceberg analogy, is that they're on the point of crisis. And this is not where you teach, and this is not where the person's going to learn. What you're going to do is you're going to make sure that people are safe, that you're going to get through this, and that you have a plan in place so that nobody is going to be hurt. You want to build that relationship. You want to have functional communication supports, not yours, but the individual. How do you assess the efficacy of that support? Well, you make sure that during the day that this person is able to follow a schedule, or they're able to use their augmentative communication device, whether it's, they use Proloquo to go, or they're using whatever multitude of applications that are out there. Does this person use it independently? Then we can assess its efficacy. We need to stop and ask again, what need is going unmet? We need to look at those teachable moments, and those teachable moments are time of opportunity when the brain and the sensory system are receptive to input. Let me say that again. A teachable moment is the times of opportunity when the brain and the sensory system are receptive to input. We want to be proactive rather than reactive. Reactivity, there is no teaching, no learning being done. And I hear this a lot, but I'm giving into their behavior. Meeting someone's communication needs does not equate to giving into a person's behavior. When the goal is to create teachable moments by reducing stress and anxiety so the person can learn another functional, efficient way to meet their needs, that is not giving into a behavior. That is helping that person learn a new skill. But again, let's go back to understanding that the brain has to be in that place. Where did I put it? All right. I don't know where I put it. Anyway, time and opportunity when the brain and the sensory system are receptive to input. Those are teachable moments, and it's not about giving into a person's behavior. So I'm we've got about 22 minutes. And so now I'm going to talk about implications of support based on these characteristics that I have just talked about. So the first is communication and language problems. So I talked about the symptoms. I'm not going to reiterate those, other than oftentimes being either nonverbal, can be limited to the number of words that they can say, echolalia, concrete, literal. The implications of supports is that we know that the person, what we need to do or understand that learn the communication strategy of the person is skilled in, whether it's visual icons, a written list, an augmentative communication device, by gesturing. There's a whole lot of things that we need to learn first, because I can tell you, the unfortunate reality is, let's say we have a child that is in before and after school childcare, and they go into the before school and nothing is structured, and the child is having a lot of difficulty. And that being said, they have a one-on-one that's with this child all the time, and then they go into their classroom and the expectations are completely different. The fact that we have the person who, with autism or any disability for that matter, they have a disability, and the fact that that person has to adapt to every person in their life, and that each and every person starts a whole new communication system for the individual, we're not doing that person a favor. We're only doing it for ourselves. We have to take time to learn what has the person learned, and we want to build from that. We know that people with autism, their eyes work better than their ears. So visual structure and routines, that person needs to learn the power of communication, whether it's through a picture exchange communication system, whether it's through following a visual system, whether it's by using an augmentative communication device, rather than engaging in a self-injurious behavior as their mode to communicate. It's oftentimes we need that person to understand that using communication supports is the most effective, efficient way to get their needs met. Teaching strategies of verbalization and imitation is really not effective. We can teach somebody over and over and over again. Matter of fact, I had somebody say that to me just the other day. It's like, I tell them over and over and over, and they still don't get it. And I'm like, how's that working for you? Einstein said, if you do the same thing over and over again and expect a different outcome, that is the definition of insanity. We have to think, what does this person need, so that they can get an understanding of what are the expectations. We know that communication should be a two-way street. So I hear you and follow your directions or not, but does that mean we are communicating? No. What that means that there's a communication difference. So a person who actually follows your direction, does that mean that they're in communication? or are they following directions? And it means that they have receptive language and they're following direction. That does not mean that they're communicating. So communication differences are one of the diagnostic criteria of autism. It's part of that diet of impairment we need to pay attention to. Understanding communication traits of a person with autism is necessary by one of those necessities for increasing the ability to have meaningful interactions and relationships and friendships. It improves community life. It supports independence, choice, and autonomy. If you're always following someone's cue and direction in prompt dependency for a first-time learner, they will always follow your directions, follow your cue and your prompt dependency, and will not learn independence. You have to try it in a different way. Again, communication is interaction. It's an interactive exchange between two people to express needs, feelings, and ideas. It is literally a fundamental social skill. An effective communicator is motivated to interact with others, a desire to express something, and a means of communication. And oftentimes that is something that a lot of people with autism, they don't feel the need to socialize or interact with another person. Their socialization might mean something completely different, or they just don't have that need. An effective communicator is constantly thinking about multiple contextual, language, social, and emotional aspects of the situation and making ongoing adjustments in response to the behavior of another person. Again, this is not always the circumstance for the person with autism. When you're looking at the multi-contextual, navigating and being able to adjust to nonverbal cues, the emotional aspects of a person, and make adjustments to the response of the behaviors of another person that's why it is considered a social communication, repetitive behavior, diet of impairment, diagnosis of a neurodivergent brain. Communication can be expressed verbally by means of spoken or sign or voice output communication device or written language, or non-verbally by using pictures, picture exchange, gestures, emotions, other behaviors. The social convention of communication are learned and refined throughout development. Lifelong learning starts and ends with effective, efficient communication. And I have started picture exchange communication systems with people in their 40s, 50s, and 60s. So when people say, oh, that window of opportunity is gone, let me tell you, it's not. It's not conventional, and most people in the adult service arena don't know what that looks like. And typically, that's the unfortunate reality, is that people don't understand that individuals are lifelong learners. I know I am. I continue to want to learn and want to learn new skills. And that's no different from anybody that we support as a child or as an adult. I actually had a situation where there was a person who is nonverbal, and the unfortunate situation is the family has a different ethnic background, and they don't see that their son has capacity to learn. And unfortunately, he's 27 years old. And I'm just like, oh, wow, no. It's like, I want to just jump up and down and go, no, we got this. We will do this. But at any rate, I digress. So receptive language really are people talking, that the context specific comprehension, that oftentimes there's poor comprehension of abstract social concepts, like, oh, well, your attitude was really, was alarming. For a person with autism. Attitude, what attitude? I didn't even see that. So somebody who's a literal concrete thinking is like, alarming. I didn't even hear a siren. These are some of the things that we need to take into consideration. The things that we say, that will make and can make a difference. You know, that language component of echolalia, verbal rituals. You know, I've had people that will say things to themselves and they basically talk to themselves and they are using it as a way to calm themselves in a difficult situation, or expressing anxiety or withdrawing from a particular situation, or expressing some emotion. I mean, these can have verbal rituals to it. And using augmentative communication devices, we can increase communication competency. We can increase rate of developing speech in comparison to those who don't use augmentative communication systems. Not saying that everybody needs an iPad. That's not what I'm saying. There's so much more. And there are so many things that we can use. It is engaging a speech and language pathologist, or an instructor that has a good understanding of what, the value of language, the value of communication. And then also augmentative communication devices can decrease the rate of problematic behaviors if we are consistent. It's not a magic, wand. It's not a silver bullet. Again, I'm using, idioms here to describe, things that it's not going to be the end all. It's not going to be perfect, but it certainly can be a start that we can work on and build on. Visual supports help the person because it is a strength that is inherent in the diagnosis of autism. It plays to the strengths that parents and professionals can use and develop. And there has been huge amount of research. I mean, when you look at picture exchange communication systems, if you look at Division Teach, they have been around since 1973 out of Chapel Hill, North Carolina, that focuses specifically on visual supports. Now you have all these augmentative communication devices that have a visual that provides a augmentative communication output. Visual representation is going to be what is going to help the person organize and sequence the events that are happening. It enhances the ability to understand, anticipate, and participate in events that will be coming, that are in the future, or what will be currently being asked of them. Visual communication, a person can complete more tasks for themselves independently. They can learn more rapidly. They demonstrate decreased levels of frustration, anxiety, and aggression, and adjust more readily to changes in environment when they're a visual communication. Can you imagine going to a grocery store and there are no signs? There are no signs anywhere. You would wander up and down each and every aisle trying to look for peanut butter. Or you'd be like, could you tell me where the olives are? Excuse me, could you tell me where the napkins are? There's a reason why they're in place, because it helps shoppers be independent, and that it will decrease their frustration and anxiety, and they're able to complete their tasks because we use visual clarity. We use it while we're driving, for heaven's sakes. Stop signs, yield signs. We've got double lines. We have yellow lines. We have all the things in our environment that are visual, because it's universal. And that we can do for people who are visual communication or visual learners. And like I said, if we have people that are saying something or asking something over and over again, we need to understand that they're not understanding what's being asked of them. And we have to provide them in a different way information, so that when we present information, the words are available and that they can actually take it in. Otherwise, when we say it, it disappears. Words disappear. And you'll have to ask again, what did you want? Where am I supposed to go? Rather than if it's on a visual and Tim says, where am I supposed to go? Let's look at your schedule. Look here. So now we're teaching them to focus on something else rather than always being cued or prompted by someone. Let the person know what's going to happen. It's just out of respect and dignity that we need to provide that. Where do I need to start? I mean, through the pandemic, we realized, if we put spots every 6 feet, people will know where to go. Otherwise, let me tell you, they'd be stacked up in the grocery line, nose to the back of the head. It's just, we need to understand, what does that mean? What does 6 feet mean? How do we teach what 6 feet? Well, stores and pharmacies and everybody else, they figured that out. You know, being unable to talk doesn't mean that a person doesn't have something to say. So here's an example of 3 different ways of saying the same thing. So using an icon that, an abstract icon of a car, grocery shopping, haircut, and then home. Then we have on the top right is a checklist: car, grocery store, haircut, go home. Or we use real live pictures: a car, grocery store, get a haircut, but in a barber shop, and then go home. It is a process to try to figure out what's going to be the most intrinsically motivating for the individual. You know, having the person be able to tell what's going on with their body. We've got social judgment. You know, we know that people do not learn from watching other people. That's how, being neurotypical, we socially watch how people are acting and we adjust our behavior. That isn't always what happens to a person with autism. They need a social narrative that helps them understand, either using, you know, a social narrative or a social story that gives them the description, the perspective from somebody else's point of view, information and direction, and the real life implications of proactive supports, like giving a person a social narrative to say, this is what's going to happen. These are the expectations. So the person knows what's going to happen. All right, I'm going to jump a little bit. I want to get into all of the supports when it comes to so we have people with social cognitive differences, that they have difficulty reading emotions in others, recognizing emotions in themselves even, may have physical manifestations, but they don't know what's even going on, can be extremely literal. We need to understand that that is part of the impairment in social communication and interaction. It's part of that social cognitive deficit that is the actual diet of impairment, that first pillar. And so, you know, recognizing the emotions in others, we can do that in a social story. We can define the difficulty seeing things with somebody else's perspective, and then using that social story, they're able to help them understand what's going on. It's much different than a social story versus what the rules are. The rules are at the table. Everyone eats from their own plate. No eating from your roommate's plate. If you want more food, you ask your helper. Versus Mary eats food off of Tim's plate. When Mary eats the food from Tim's plate, Tim gets angry. Tim is hungry too and wants to eat his food. That's the perspective that Mary doesn't understand. If Mary wants more food, she can ask Stephanie for more food. When Mary asks for more food, both Tim and Mary can be happy. I want to get to, this is the organizing and sequencing problems. Implication of supports is emphasizing visual clarity, systematic or routine ways of doing something. Uneven scattered of patterns of development. It's an individual approach. Must assess the full range of skills and not make an assumption on a splintered skill that person has that full range of skills in all domains of their life. And we can, like I said, can't assume one skill in one area over another. Restricted repertoire behavior. We know that work is easier than leisure, downtime, and breaks. When we tell kids it's time for a recess, oftentimes we have kids that are either going to go out to the playground and they're going to go the same thing over and over again, or they're going to walk the perimeter of the playground. Or if there's, for adults, oftentimes when we say there's, you know, we have downtime or there's a break, that's when unstructured time becomes very difficult, and a person can often engage in ritualistic behaviors that may sometimes not be socially acceptable. I won't get into what those might look like, but I'm sure your mind can wander. Need predictability. Routines that are developed, we need to develop the first time the right way as a first time learner. And we know that a person can learn in a positive manner, although these are considered basically deficits, we want to use them to as a positive approach. Sensory and perception problems is minimize distraction, highlight important elements of the environment, provide a sensory diet strategies throughout a person's day. Taking, like for children in school, taking them out of the situation and provide sensory with an occupational therapist in another room is not going to be successful. They need to be able to figure out how to use it in the environment that they need help in. We know that, there's tactile differences for a lot of our folks that could be, puts us in a protective situation. We have discriminative, which some people can understand what they're feeling, like what I can feel on my purse, and yet a person with autism feeling it doesn't always generate the picture in their head. Sometimes the functional tactile system, the ability to enjoy a hug, is sometimes different for a person with autism who wants a hug, who's actually looking for proprioceptive deep pressure input. So we need to actually help the person understand that functional tactile systems play a role in our ability to understand personal space, the relationship to others, and really will impact our social relationships with others. We're getting close to the end here, and I'm just talking. So there's a reaction to touch, not wanting to be touched. They don't like to get their hands dirty. They may not like getting their hair cut or combed or even brushed. May strike out or withdraw when unexpectedly touched, or the person may not feel pain easily or have a high threshold of pain, may seek rough surfaces, may put non-food items in their mouth, or maybe licking or may lick something. Strategies for sensitivity to touch: give the person's face, give the person a warning that I'm going to touch, I need to touch you. I'm going to comb your hair. Provide a firm but gentle touch and not a light touch, because that could put a person into a fight or flight. Consider, having clothes that do not have tags on them, because they become itchy. And that's why we have a lot of people that have a preference to a style of clothes, to a certain fabric of clothes, because it is something that that's reliable, that is not going to be bothersome to them. People can be very distracted with different, very distracted with light. It can be either it's too bright or it's, too dark. The function of the eye is to give the information about objects and people. Sometimes that can be, again, this is a neurological, a neurodivergent brain that sees things and provides information in a different way. And so as though it gives us information that tells us what's beyond our arm's reach, such as distance, proximity, and depth perception, that might be compromised by that person with autism. And then, the effective processing helps us to identify physical features on people, events, and objects. It plays in the role in the development of pattern recognition, and attributes to the reason people with autism are first-time learners, are visual learners, and are great at patterning. I'm not going to get into this. Is the whole other, I hope you read this. This is for visual thinkers, but I want to get into the auditory, that speech, sound, noise can be very hard for the brain to distinguish and to interpret by the brain. And that's why receptive language can be very difficult. And so we use our auditory, we use our hearing as the basic for developing oral language. But when it's compromised, it may also be delayed and be ineffectual for the person to develop oral language skills. The reaction to sounds could be the person put their hands over their ears, they try to escape the noise, they become very upset, or they might start humming to block out other noises, or they seek noises so that they can control the noise themselves and block out what else is going on. May not even respond to their own name when it's being called. We might need to talk more softly or slow down. Use short, direct sentences. Don't chatter on and on. Tell the person what to do. Again, that situation, this young man that again I was working with this morning, job coach and mom, they're saying, oh, no, don't go there. Don't go there. No. This, I mean, they're just yelling. And I'm like, stop. Basically for them, but for the young man, I said, stop in the house. It's just like, it just kind of like jerked him and he turned around and went back in the house. And I'm like, how did you do that? And I said, you were giving him too much verbal input. He couldn't distinguish from it. He just needed a short, direct sentence. And I didn't ask him, is it all right if I talk to you this way? I just gave him, this is how, what he needed. And that's what he needed to be. One, he needed to be safe. And two, he was just going to continue to go on and on and on and go further down the block because he was not listening to anything that was being said to him. Olfactory, that sense of smell, it is connected to the long-term memory. It is one of the senses that is connected to long-term memory, and it helps the person distinguish from different people, from different things, what is clean, what's dirty, what's poisonous, what's leaky gas, what's smoke. It also plays into PTSD because it is one of the strongest senses that recalls negative processing. It is when people smell things, it can be a very positive effect. You know, if I smell roses, I think of my dad and his and all the roses he had. But if I, smell something like, the garbage dump, it's like, ooh, that's just, I don't want to smell that, or smell something that smells like garbage. It's like, oh. So we also know that behavior can be triggered by our olfactory senses. Taste detects our mouth actually detects 4 or 5 tastes, which are sweet, sour, salty, bitter. We have a lot of people with autism that have aversions to different flavors, to different things. That also has to do with the fact that our taste and smell are very, very connected. That's like when you have a cold, it's like, I can't taste anything because I've got a cold. It's because your nose has those smell receptors that actually identifies a lot more in the flavor than just those 4 that we had identified. So we might have people with autism that one, it could be texture, one, it could be taste, one, it could be smell. It could be a combination, but it's trying to figure out what and why this person is reacting to these different things. And I'm not going to get into synesthesia, although it's very interesting. There are some people who, like, for instance, they can see numbers and colors, or they might smell a song. Synesthesia is a very interesting, and believe it or not, 30% of people with autism actually have synesthesia. Vestibular, it's our vestibular system tells us about our balance. They're located in our inner ears. That helps us be with our movement. It gives us information about where we are in space and how fast we're going. It gives us the overall posture and muscle tone. It also tells us, oh my gosh, I'm sick because of motion sickness. And then we have people who need proprioceptive input, meaning you've got a child that is seemingly just bouncing off the walls, that runs around the room. This is a person that is likely going to benefit from proprioceptive input, meaning they might need to go for a walk before they go into a classroom where they have to be sitting and attending to instruction, because the proprioception or proprioceptive input is going to help that person be able to regulate their anxiety. What it does is actually helps release natural enzymes in our bodies, natural chemicals like epinephrines and dopamines. It helps us relax, and that's what proprioceptive input can do for people that we support. And it's giving, deep pressure and body pressure, and these are some of the ways that will be on your handout. Interoception is the 8th sensory system that talks about what's going on inside your body. There are a lot of people with autism that don't recognize that they're hungry, or that they're thirsty, that they need to use the bathroom, or they need to throw up or have a bowel movement. They don't they don't recognize that. And this is called introception. And it's, like I said, it's a process of what's going on inside the body. And that, all of a sudden it seems like this person is like, I didn't even know that, all of a sudden they had an ear infection and their eardrum burst when they probably had a lot of pain. They just didn't know how to express themselves. Sensory processing is the ability to take in information received from our senses, both externally, internally, and then use the information to functionally and effectively help us or save us, or be as a safety precaution. Our bodies send information senses to our brains through neural pathways. And when you have a neurodivergent brain, those pathways sometimes can be compromised. But we know that once the information reaches the brain, it's interpreted and then it can be acted on. For people with autism, those neural pathways may be compromised. How do we know? We need to take data. We need to take in information. So I'm not going to get into the medical physiological, because we are 7 minutes after, and I think we started at 6 minutes after. So that is the 2 hours I have for you. But please, this is in your handout, is the medical, physiological, and mental illness comorbid diagnosis. That's usually I have this for either a 3 to 5 hour training. So I was talking a lot. So is there any questions, anything that stood out for you that you're like, or any like ahas during this?
I would say I had a lot of ahas, which is funny because I know a lot about the spectrum of autism and have worked with a lot of kids on the spectrum. But I have a random thought. I use this book a lot with my clients. I don't know if you can see it because I'm blurry. It's called Meet the Overs and Unders. And it's an activity book by an OT that talks about all the sensory processing and sensory needs and the overstimulation and understimulation and how that works in kids and adults. And I use that a lot and it's super helpful. I had a lot of ahas during that conference, like reading it, because I was like, oh, that makes so much sense. But while you were talking, I was like, this all coordinates.
Right. Yeah. Even when I do the trainings, I mean, and these are my trainings, I'll hear it over and I'll hear myself and I'm like, I mean, I know this. And sometimes it's just a great reminder to like, and inevitably I'll be doing the training. That's why, I mean, all the people that I've worked with, I can give examples. And the sensory processing, it just, for the first, really sensory processing hasn't really been acknowledged until these last 20 years. Really, the effects that sensory processing does, I mean, for everything that we do, whether you're neurotypical or neurodivergent, it's like we all have sensory needs. After I get done with this, I'm going to go up. My office is downstairs, but I'm going to go upstairs. I'm going to put my pajamas on because those are soft and cuddly. That's a sensory need. I'm going to have a cup of tea because that's a sensory need. Those are routines. And, we don't always look at why a person engages in things or why they need certain things. We can really help a lot of our students, a lot of children, a lot of adults when we recognize what their sensory needs are. Most definitely.
And then there's another visualization tactic that I've used before that kind of reminded me whenever you're talking about like a color system when they are either nonverbal or like somewhat nonverbal. I've had a lot of clients where they go nonverbal when upset or in crisis. So we use color systems with them as like a visual slash they can just point at it.
If you're not familiar with, there was a occupational therapist. I can't remember. Her name is Carrie Barone Dunn, and she wrote a book and it's called The 5-Point Scale. And it is literally about, and it is a whole curriculum on Identifying, being able, it's a teaching strategy to help a person understand what their emotions mean, what they can do for themselves. And it also helps like any teacher or support person, that if we want to, when we can say, we can look at something and say, Noah, it looks like he's at a 3. This is what we can do. Because if Noah isn't able to recognize that of himself, we can certainly provide that to our instructors, respite care providers, or, whoever. And if, like, for instance, I did one not too long ago, and it was a young man who liked dinosaurs. And we started off with a little tiny salamander that was just a little tiny salamander. And we went progressively up to a fire-breathing dragon. That was a 5. That's when, literally everything's breaking loose. And this is, we gotta, this is a crisis. So it's, I would highly recommend that. That's for sure.
That's cool. I'm gonna look into that.
Yeah, good. And
I
there's
had a
another one called
question.
the Incredible 5-Point Scale, which is also a really cool thing.
The autistic people are visual learners, but you didn't mention sign language as a means of communication. And I was wondering, is it because we sometimes have a hard time copying the body, or?
That is an interesting there. Again, it's when we say a word, it goes away. When we use a sign, it goes away. So although, because I can write something down and that's visual, it stays there. But when we sign, you could have a visual sign of a sign language, but and that would stay there. But when we use sign language, sometimes it is helpful for a person with receptive, somebody who has difficulty with receptive language, but it doesn't help them decode language. And sign language, although it has been, used as an alternative, there's research that states it's visual, and yet it's still not visual enough, if that makes sense.
I mean, I recognize that stop when you did that early. I was like, oh, that maybe using a few signs in your
Yes,
but
true.
but don't depend on it.
Exactly.
Use it. Okay.
It's funny that you say that, because my son, I'll say something to him, I'll say, Michael, and he looks at me, he goes right back at me. So he uses sign language lately at me too. It's just like, I think.
And I remembered the other thing that hit me was the interoception, and how my daughter doesn't recognize when she's thirsty, and I don't recognize when I'm hungry or think, it's just that's another sense that we forget about.
Yeah. And there are times that even for neurotypicals that you can like, man, I just don't feel right. I just don't feel good. I can't quantify it, but I just don't feel good. Well, think about that. I mean, for a lot of our folks, that's with everything. And all of a sudden, I've had people that were employees that went to work, and they got to work, and then they threw up. And it's like, what happened? And it's like, didn't they know that they were sick and they have a fever? Nope. They didn't even realize, because they just got up. They just, life is life. And I would say, I don't want to give everybody a sweeping generalization that no, everybody doesn't recognize. It means that there are some people that don't, some people that might even have, highly acute feelings of things that are going inside their body. Oftentimes it's just that they're not able to say, you know what, I think I have to use the bathroom. Matter of fact, there are times where people that I've worked with, I have to put it on their schedule to remind them to go to the bathroom, because they're not going to initiate it on their own. Even if they're ready to explode, they're not going to initiate it. And I've had adults wet themselves because they didn't know how to initiate it. And then, you know, people get upset. Well, oh my gosh, he's an adult and he's wet himself. And it's like, yeah. So, I mean, did he know when he could go? Did, you know, was it on his schedule? Did, you know, does he know that he can say, I need to use the bathroom? And a lot of those occasions that hasn't happened. That they have been compliant, trained. You don't initiate anything on your own unless I tell you. And unfortunately, those are some of the results of it. And that's unfortunate. Well, if there aren't any more questions, I'm happy, very happy and delighted that you were able to be with Malia and I today. And I hope you'll look forward to more trainings that Malia has with the Parent Coalition. And I will be providing additional trainings in the future as well. My website is also on the handout. Feel free to look on that. I haven't updated it in a couple of months, but it does have all the trainings that I do provide, and do provide for teachers clock hours when requested, and continuing education credits for Developmental Disabilities Administration. So
Awesome.
all
Okay,
right.
so I just posted that this will be posted to the YouTube channel by tomorrow. So,
Awesome.
which reminded me that I need to stop recording. So recording stop.
Perfect. All right. Well,